Welcome back to the deep dive. If you're stepping into modern pediatric healthcare, well, you know it's way more complex than just the hospital floor these days. Whether you're getting ready for clinicals or just need a clearer picture of where kids actually get care now, this deep dive is definitely for you. We're focusing on a really comprehensive overview of pediatric nursing across all sorts of settings. We're pulling insights straight from our source material, caring for children in diverse settings.
Right. And our mission here is to really boil down the key concepts nurses need today. Understanding things like the big psychological stressors of being sick or hospitalized, and exploring those specialized nursing interventions required to support not just the child, but the whole family. Because honestly, the whole landscape has shifted. Understanding that is just critical for good outcomes.
Yeah, absolutely. So before we jump into those specialized roles, maybe we should clarify some terms. The sources make a distinction between community health nursing and community-based nursing. Sounds a bit academic maybe, but it seems like the difference really defines the job.
It absolutely does. Think of community health nursing as population-focused. Big picture stuff like tracking immunization rates for a whole school district or maybe running health screenings across the community. It's about preventing disease for the group. Okay, so that's the macro view. Then community-based nursing must be the micro. Exactly, spot on. It's applying nursing care to individuals or families outside the hospital. So that's your school nurse working one-on-one with a student who has, say, severe asthma, or the home health nurse visiting a child with really complex medical needs. It's direct care, right, where the child is living or learning.
What really jumps out from the sources is how dramatically care location has shifted. We know tech lets us do complex things outside the hospital now, but what's really driving it? Is it just money, or is there a clinical reason too?
It's really both, and that's key. Yes, you've got strained budgets and shorter hospital stays pushing for cost savings. That's undeniable. But clinically, the hospital, well, it's often not the best place for a child's development. Home, school, even specialized daycare. These places feel normal. So moving complex care like IV antibiotics or even managing a ventilator at home, it actually supports the child's long-term development. It's better for them.
Right. And when the nurse moves into the community, their role just explodes, doesn't it? Less hands-on maybe, but suddenly they're educators, care managers, advocates. They need incredible assessment skills, not just for the child, but for the whole environment, the home, the community resources.
And that leads us to these specialized roles, like in schools. The school nurse's main goal, it's actually promoting academic success by tackling health barriers. And a huge tool for that is the Individualized Health Plan, the IHP.
Okay, the IHP. So it's a formal, written plan for kids with complex needs, maybe type 1 diabetes or something similar. Sounds great on paper, but what's the biggest hurdle for a nurse trying to make that IHP work with school staff who aren't medical?
That's exactly the challenge, communication and, frankly, enforcement. The IHP is built with the family and the doctors, laying out exactly what needs to happen at school, but the nurse's job is translating that complex medical stuff into clear, simple actions for teachers, aides, bus drivers, anyone involved. Think about an asthma attack. The IHP lists the steps, but the nurse has to ensure everyone knows their part, especially if there's a substitute teacher or during a field trip when regular staff aren't even there. It's tricky.
Yeah, I can see that. Another setting mentioned is medically fragile daycare. That term itself, medically fragile child, sounds quite specific.
It is. The source defines it as a child with pretty substantial health needs, usually chronic conditions, often needing technology like feeding tubes, monitors, sometimes even ventilators. These centers have trained nurses and therapists on staff.
Wow. So these centers are like a bridge, maybe, between being hospitalized long-term and being fully at home. What are the big advantages for the family?
Well, the benefits are massive. First, cost, it's much cheaper than long-term hospitalization. Second, it drastically reduces social isolation for the child. They get to interact with peers. And third, you actually see lower rates of rehospitalization because they're getting consistent monitoring outside of a crisis. Plus, those age-appropriate social interactions, invaluable.
Okay, let's shift focus a bit to home health care. The source really stresses something that I imagine trips up new nurses. In the home, you're a guest, which means embracing true family-centered home care, seeing the family as the real experts on their child's day-to-day.
Absolutely crucial. That respect is key, especially when you encounter different cultural beliefs about health or care. And that's where the LEARN framework is such a useful tool for communication. It makes you slow down, build actual collaboration.
Okay, let's walk through LEARN. It sounds like a really practical way to build trust.
It really structures the conversation. L is for listen. Really listen, empathetically, to how the family sees the situation, the illness, the needs. E is explain. Share your professional view, clearly and simply. A is acknowledge. Point out where your views and the family's views align and where they differ. Respectfully. R is recommend. Suggest interventions based on best practices, clinical guidelines. And then, the hardest part maybe N is negotiate. You have to work together to agree on a plan that works in their real life, respects their culture, and is actually feasible. Like, if you recommend a complex dressing change 4 times a day, but the mom realistically only has 2 solid windows to do it, you negotiate. You find a schedule that works and supports her ability to follow through.
Yeah, that totally shifts it from just giving orders to building a real partnership. Okay, let's pivot back to the acute care setting, because even with community care growing, hospitalization still happens, and it's often traumatic. The source identifies 3 big psychological stressors for kids in the hospital, whether it's planned or an emergency admission.
hmm And these really define the child's whole experience. First, anxiety and fear. It comes from everything being unknown, weird equipment, strange sounds, people in masks, and especially the fear of pain, needles particularly.
And the second one, loss of control, feels like it's everywhere, but maybe less visible. Their whole routine is gone. They might be stuck in bed with an IV. They can't refuse painful things.
Right, which leads directly to the third major stressor, separation anxiety. This is huge for younger kids, usually kicking in around, 4 to 8 months
Yeah.
when they get object permanence. And we still talk about those classic 3 phases from Robertson and Bowlby.
Can you remind us of those? Especially detachment. Why is that one less common now, but so worrying if you do see it?
Sure. Phase 1 is protest. The child is actively fighting it, crying, screaming, maybe lashing out, rejecting comfort from staff. Very noisy. If the parent doesn't return, they can sink into despair. This looks like apathy, withdrawal, quiet sadness. The child is essentially depressed. Detachment is the third phase, usually seen after longer separations. It's a defense mechanism. The child might seem okay, they might interact superficially with nurses, play a bit. But then when the parent does return, the child ignores them or seems indifferent. We see it less today, thankfully, because stays are shorter and we encourage parents to be there. But when you see detachment, that signals some deep emotional hurt. It's a really bad sign about their coping.
Wow. Okay, and how kids react to all this stress is totally shaped by their age and development, right?
Absolutely. Take a toddler. They're all about me, do it. Autonomy. So illness and separation, huge threat. Expect tantrums, fierce resistance, and often significant regression. Like a potty-trained toddler might start having accidents again or refuse to feed themselves. It's a power struggle.
Then the preschooler. Their imagination is running wild. They have limited understanding and that magical thinking. It can be a real problem.
It really can. They might take things literally. Take your blood could mean you're taking all of it. And critically, they might believe the illness is punishment for something they did wrong. Nurses have to actively counter that idea.
Makes sense. What about school-age children?
Their world revolved around competence, achievement, friends, what Erickson called industry. So they worry about falling behind in school, losing friends, or permanent disability, or even death. They fear losing their place. Helping them feel competent, maybe by giving them small tasks related to their care or schoolwork, is key.
And finally, adolescence.
For teens, it's all about body image and independence. Separation anxiety isn't about parents anymore. It's about their friends, their social group. And because they often have that feeling of being invincible, losing control over their body or activities can lead to real anger, withdrawal, maybe noncompliance. It hits their identity hard.
And we can't forget the rest of the family. Parents often feel guilt, maybe denial, anger, sometimes aimed at the staff, right, as a way to feel some control.
Exactly, it's common. But we also really need to think about the siblings.
Yeah, they often get overlooked, don't they?
Terribly overlooked sometimes. Siblings can feel intense fear, jealousy because the sick child gets all the attention, or if they're preschoolers, that magical thinking again, they might worry they caused the illness somehow. So psychosocial support for siblings is vital, especially if the illness is chronic or serious. The nurse needs to check in, see how they're doing, maybe help the parents talk to them.
Okay, so that brings us to the what do we do about it part. The action plan. The sources frame everything around family-centered care and atraumatic care, basically minimizing distress, both physical and psychological. What are some key strategies from the text to boost that sense of control and safety for the child?
Well, preparation is huge, but timing is everything. You can't tell a preschooler about surgery next week. They'll just worry endlessly. For preschoolers, you give them concrete, simple info, maybe a day or two beforehand. For adolescents, though, You can give them detailed explanations maybe a week or even 10 days out. They need time to process, ask questions, feel involved.
Right. And to combat that feeling of powerlessness, offer choices whenever possible.
Exactly. Not if they get the medicine, but how. Which cup, which flavor of juice to take it with, what color bandage. Let them pick their pajamas. And try to incorporate home routines. Even small things like a specific bedtime story or song bring a sense of normacy and control.
Safety measures also need to be age appropriate. The source mentions Table 11.2, which contrasts safety for different ages. Can you describe that a bit?
Yeah, it's a good visual. For infants and toddlers, it's mostly physical barriers, keep small objects out of reach, crib rails always up, that kind of thing. Basic environmental safety. But for a school-age child, safety involves understanding. You explain why the side rails are up. It's a hospital rule to keep you safe while you sleep, not because you did anything wrong or we think you'll fall out. It's about rules and reasons, not punishment.
Okay, let's tackle maybe the toughest safety issue, restraints. The text is very clear. Last resort only, but how does a nurse maintain that atraumatic approach when they actually have to restrain a scared, maybe fighting child?
That's incredibly difficult. It's more than just following the protocol, though, that's essential. Checking circulation hourly, removing the restraint every 2 hours for range of motion, documenting everything. The real work, the atraumatic part, is constant communication. You have to tell the child and the parent why it's happening. This elbow restraint is here just for a little while to help keep your IV safe, so you don't need another poke. It's not a punishment. You have to validate their fear and anger, and I know you hate this, it must feel awful, while still enforcing the safety need. It's a very fine line.
That sounds exhausting, but so necessary. Okay, another key intervention, play. The source distinguishes between just playing to pass the time and actual therapeutic play.
Right. Unstructured play is great for boredom, keeping up motor skills. But therapeutic play is a specific intervention planned by the nurse or child life specialist. It helps the child work through feelings and fears, like using those shadow buddies dolls customized with, say, a scar or an ostomy pouch just like the child's. It helps normalize things. Or sometimes supervised needle play, where the child can give a doll an injection, acting out their anger or fear in a safe way.
And the absolute golden rule for play.
Never perform any procedure, especially painful or scary ones, in the designated playroom or activity room. That space must stay a safe zone, a sanctuary. No needles, no meds, nothing medical in the playroom, period.
Got it. Okay, finally, we reach the end of the hospital stay, hopefully. Discharge. But the planning starts way earlier, right?
Oh yeah, discharge planning ideally starts on admission. You're already thinking about what the family will need to manage at home. For really complex cases, sometimes they even do a trial run of home care while the child is still in the hospital, just to build confidence.
And the actual discharge instructions need to be crystal clear and practical.
Absolutely. Always provide written instructions.
Yeah.
They need details on follow-up appointments, medications, dose, route, timing, side effects to watch for any diet or activity limits. And critically, if there are procedures the caregiver needs to do, like wound care or giving injections, the nurse needs to watch them do a return demonstration to make sure they understand and can do it safely. You can't just assume they got it. So if we wrap up this deep dive, seems like 3 main takeaways emerge. First, pediatric nursing is spread way out into the community. Nurses need to be managers, educators, advocates, way beyond the bedside.
Right. Second, those big stressors, separation, fear, losing control, hit differently depending on the child's age and development. You have to tailor your approach, remembering things like magical thinking in preschoolers or an adolescent's focus on body image.
And third, all our interventions have to be filtered through that lens of atraumatic care. It's about minimizing distress, physically and emotionally, and truly empowering the family as partners in care.
You know, the biggest challenge seems to be that constant balancing act for the nurse. Balancing the high-tech, often intense medical needs with the equally important need to support normal childhood development and family coping under huge stress.
That's it, exactly.
So here's something to think about. We know families react differently based on their parenting styles, their cultural beliefs, the support they have. How much does that very first interaction with the nurse, that initial assessment, that first conversation, really set the tone for how that child and family will cope long term? How foundational is that first connection? Something to mull over.
Thanks for joining us for this deep dive.
We'll see you next time.